So welcome everybody and good afternoon. Thank you for attending this webinar on proximal weakness organized by EuroNMD in partnership with European Academy of Neurology and ERN R&D for rare neurological diseases. Thank you to our today's speaker, Dr. Crystal Clays, for taking the time to share her knowledge with us. A little presentation about Crystal. She's a neurologist specialized in neuromuscular disorders, working at the University Hospital Leuven in Belgium. She's affiliated with the largest neuromuscular reference center in Belgium, together with her colleague and neuromuscular neurologist Philippe Van Damme. She's appointed as an associate professor at the University of Leuven. So we kindly remind you that today's webinar is recorded and will be available on our website and YouTube channel. Don't hesitate to write your question in the chat box. Crystal will answer at the end of the webinar. Thank you again all for your participation, and Crystal, the floor is yours.
Thank you so much, Elizabeth, for this nice introduction. You can hear me?
Yes, very well.
Great. So, dear colleagues, so the topic of today is proximal weakness. And so, of course, proximal weakness can be caused by many different diseases, both in the central nervous system and in the peripheral nervous system. But we will mainly focus on the peripheral nervous system, so on the neuromuscular causes of proximal weakness today. This does not only involve muscle diseases, but also non-myopathic diseases like peripheral neuropathies, like neuromuscular junction diseases and anterior horn cell disorders. So proximal weakness can be, the cause of proximal weakness can be localized in one of those four systems that are comprising the neuromuscular system. So in this presentation, we will first focus on myopathic, so on muscle disorders with a genetic cause. We will start off with limb-girdle muscular dystrophies and then talk about the differential diagnosis. Second, we will talk about the acquired muscle disorders as a cause of proximal weakness. And third, we will focus on a few non-myopathic disorders. So first of all, limb-girdle muscular dystrophies, LGMD. This is a heterogeneous group of rare genetic muscle diseases, and they are characterized by a progressive, predominantly proximal muscle weakness. As you can see here in this graph or in this presentation, you see here the shoulder muscles, the upper arm muscle weakness in red, and the pelvic and thigh muscle weakness. There is a variable symptom onset in LGMD. It can be early or up to late adulthood. The creatine kinase, CK levels are usually elevated. There are degenerative changes on muscle imaging, as you can see here in this example. So this is a transverse section through the thigh. And you see, so here, this is gracilis and sartorius muscle, which are spared. So you see a normal muscle appearance, but you see, for instance, here the hamstrings, that they are really much whiter. So they are clearly affected. So there's a fatty infiltration in those muscles. And in these LGMDs, we also see dystrophic changes on a muscle biopsy. So dystrophic changes, that means that there is necrosis or necrotic muscle fibers in combination with regenerating muscle fibers. So here you see the clinical presentation of LGMD. So you have a progressive, predominantly proximal muscle weakness. This is from the paper below in anoctamin 5 related LGMD, also called LGMD R12. And you see here documented the proximal weakness in the legs, proximal weakness in the arms, and you can also appreciate some distal atrophy here associated with this disease. This is another example of a limb-girdle muscular dystrophy patient where you see that he's having atrophy and weakness of the thighs. He also shows some scapular winging, and he has difficulties to put the arms above the horizontal line. So one particular exam that you can perform in the clinical examination is the Gowers sign. This has initially been described in Duchenne muscular dystrophy by Gowers. But of course, what does it mean? So you ask the patient to go to sit on the floor and to stand up as rapidly as possible. And you will see that the patient will have to push himself on the hands, so on the floor or on his own legs, to get straight up to get up from the floor. So this was originally described with Duchenne muscular dystrophy, but this, of course, you can see also in other patients with limb-girdle muscular dystrophy or other diseases with proximal weakness, because of the pelvic girdle muscle weakness, that those patients also can show a Gowers sign. This is a patient with calpain 3 related LGMD, and here the Gowers sign is also illustrated. So the patient is asked to get up from the floor, and you see he really has to push on the hands to get up due to the weakness in the pelvic girdle. And at the same time, you can see the scapular winging in this patient. This is another patient also with calpain 3 LGMD, where you see again this symmetrical scapular winging and difficulties to get the arms up in the air, so above the horizontal. Now, besides the weakness, it's also important to look at other additional clinical features. So what can we see? We can see muscle atrophy, as I showed you in the first example in anoctamin 5 related LGMD. This is another example of distal atrophy. In some cases, you can see contractures. This is an example of Achilles tendon contractures. This is an example of a scoliosis, which is also a contracture. And this is another patient with LGMD where you see hip and knee contractures. Also, muscle hypertrophy that can be sometimes from the tongue or from the calves is also an additional clinical feature to look for, and that in some cases can help you to point to the diagnosis. For instance, in these cases, so these are patients with sarcoglycanopathy, so this one and this one with FKRP LGMD. So here you clearly see this the hypertrophy of the calves here as well, and also the hypertrophy of the tongue. So besides contractures and atrophy, distal atrophy, also distal weakness in some cases, and muscle hypertrophy, also, of course, you need to take into account cardiac involvement and respiratory involvement, which in some cases of LGMD are almost always involved. Of course, you also have to take into account the family history with a potential founder mutation, so the origin of the patient and the family, and also biopsy findings can in some cases show more specific findings that can point to the diagnosis. Important to realize is that LGMD is a heterogeneous disease where disease severity and evolution is quite variable. So this is shown in this study. For instance, so here you have birth, this is the patient age, and you see, for instance, for LGMD R12, so anoctamin 5 related LGMD, you see that it starts around young adult age, and evolution remains relatively mild, but there are some other cases like this, like sarcoglycanopathies that have a much more severe evolution of the disease, where there are also cardiac problems and in some cases also early mortality. So important to look at is the family history and pedigree in the diagnosis of these patients. So here you have an example of a recessive pedigree with consanguineous parents over here. And in the same generation, you have multiple affected siblings. This is an example of a family pedigree where there are affected members in every generation. So this is an autosomal dominant inheritance pattern. So important to look at the inheritance pattern, whether there is consanguinity in the family. whether the patient belongs to a specific community and whether there could be a founder mutation. And also important to realize is that the prevalence of LGMD subtypes depend on the region and ethnicity. So we will further look with other diagnostic tools. We will test for serum creatine kinase, CK, which is elevated. We will perform an MRI of the muscles, so a magnetic resonance imaging of the muscles, which is shown here. So this is the pelvic girdle with the glutae muscles over here. This is a section, transverse section through the thigh with anterior part, so the quadriceps here and the hamstrings in the back here. And this is a section through the calves. And you see that for the different LGMD subtypes, that the pattern of muscle involvement is different. You also see here that this is still the old nomenclature of the LGMDs. I will show you later the new nomenclature. We will also perform an EMG, and this will be done especially to show that there is a myopathic trace and also to make the difference with a neuropathic trace, for instance, with spinal muscular atrophy, which in some cases can be quite similar, especially SMA type 3 and 4, especially can be similar to, for instance, Becker muscular dystrophy. And in these cases, EMG will be important also to differentiate. Muscle biopsy, including immunohistochemistry and Western blotting, is also an important diagnostic tool. And so this is an example where you can see necrotic fibers on H&E staining. You also see regenerating fibers. You see fatty infiltration, so where the muscle has been replaced by fat tissue in white here. And with neonatal MHC, so major histocompatibility complex, we can show the regenerating fibers. So with neonatal myosin, and you see here, so the many regenerating fibers. So the combination of this necrosis and regenerating fibers points to a muscular dystrophy. And Western blot will be performed in this case for a dysferlinopathy. The band on Western blot that corresponds to the weight of dysferlin will be absent. So diagnostic tools, we come to the genetics, which of course nowadays takes a very important role in the diagnosis. And as you know, we have made a very large evolution from Sanger sequencing, so the so-called first generation sequencing, where we tested single genes or several individual genes, the one after another. But nowadays, we more and more perform this next generation sequencing, so this massive parallel sequencing. There are different techniques, but where we can really test for a large number of genes at the same time. So this massive parallel sequencing, or NGS, at the DNA level is shown here. So we can either perform a targeting sequencing, where we target, for instance, 40 to 400 genes in a gene panel. So we also call this targeted exome sequencing. And a disadvantage of this technique is that you only include known genes, so you will never find new genes using this technique. And this is mainly used in diagnostics. Also used in diagnostics is the whole exome sequencing, where all the exons of all the genes are involved or are tested. But of course, no introns are involved here. And at the end, you only have 1 to 2% of the genome that is tested with this technique, which of course is already a lot. But we can even go further with whole genome sequencing, where the full genome is tested. The disadvantage of doing a whole genome sequencing is that there are many variants, that there are big data sets with high costs, and also incidental findings, which means that these are findings in genes, let's say genes for certain cancer, like breast cancer. You can find also variants in those genes, which are not your primarily genes of interests. Also, these incidental findings can be found in the whole exome sequencing. So whole genome sequencing is still mainly in research projects. So this is an example of next generation sequencing results in a large group of 1001 patients with an unexplained limb girdle weakness in whom targeted exome sequencing has been performed. So these patients were originating from many different countries. This was in the MyoSeq project, of which Volker Stroop was the PI, Newcastle University. And in this project, so 1001 patients with a limb girdle weakness, elevated serum CK, but without a genetic diagnosis were included. And in these patients, so next generation sequencing with targeted exome sequence, so with a gene panel was performed. And you see here that in a little bit more than 50% of the patients, a diagnosis of a genetic cause has been identified. But on the other hand, still around 50% of the patients, there was no genetic defect found. Why did they not find in 50% of the LGMD patients a genetic diagnosis? There are many possible reasons to explain this. Of course, a non-genetic cause, for example, immune-mediated necrotizing myopathy, of which we will talk about later. This can resemble a muscular dystrophy. So in this case, of course, because it's non-genetic, it's an acquired disease, you will not find a genetic diagnosis with this technique. Another explanation is, for instance, in Becker muscular dystrophy. So we know that in 60 to 70% of the patients with Becker muscular dystrophy, the cause is a large deletion or a large duplication of the DMD gene, and also these will not be found with this targeted exome sequencing. So then I come to what I already mentioned shortly, to the reformed classification of LGMD. We already talked about what LGMD is, but what is important here in the new definition is that LGMD, that the condition must be described in at least 2 unrelated families with affected individuals achieving independent walking. This is one of the criteria that has been included in the new classification of LGMD. And this is the result. So here you see the old name in the first column, and you know we used to call LGMD1 the autosomal dominant forms and LGMD2 the autosomal recessive forms. In the new classification, the dominant forms are called LGMD-D and recessive forms LGMD-R. And there are, for now, 5 dominant forms, D1 to D5, and 24. For now, there are already 26, but R1 to R24 subtypes. So the difference with the first old classification is that now in the new classification, 10 conditions do no longer fulfill the criteria of LGMD, and there are different reasons. So one of the reasons is that there is only one family in which the gene defect has been reported. So these have been excluded. Other reasons are, for instance, that it is mainly an Emery-Dreifuss phenotype or mainly a myofibril myopathy phenotype. So these cases have been reclassified. And on the other hand, 4 conditions have been newly included, mainly the collagenopathies and the ones mentioned here. So this is about a limb-girdle muscular dystrophies, LGMD, but of course there is a large differential diagnosis of LGMD, so other genetic muscle disorders that can be the cause of proximal weakness. So here you see this picture, LGMD in the middle with weakness in gray, so the thighs and the shoulders. And for instance, one of the differential diagnoses is Becker muscular dystrophy with a similar distribution pattern of weakness, but also, for instance, FSHD, where the weakness, proximal weakness, is mainly localized in the shoulders, also weakness associated with weakness in the face. So first of all, Becker muscular dystrophy, or BMD, the clinical features are proximal weakness and also pseudohypertrophy of the calves, as you can see here, and atrophy of the thighs, as you can see here in this patient. They often have a cardiomyopathy, which is dilated. There is a respiratory involvement possible. CK is usually high, and there is an X-linked recessive inheritance. So the family, the pedigree of these patients you can see here with females that are obligatory carriers, and then in one generation, many affected patients. And these patients, these males, have died at a younger age due to cardiac complications. So the mutation in Becker muscular dystrophy is localized in the DMD gene, which codes for the dystrophin protein. And there's around 60-70% of the pathogenic defects are large duplications or large deletions, and 30% will be point mutations. If you look at the muscle biopsy in Becker muscular dystrophy, you see again necrotic fibers and also regenerating fibers, so the dystrophic pattern. And if we use an antibody, in this case against DIS2, so this is a part of the dystrophin protein, and you see the normal control where the membranes are very nicely stained. And if you look at the patient, the Becker muscular dystrophy patient, you see that the membranes are much weaker and not completely stained. Of course, with Becker muscular dystrophy, the final diagnosis, the golden standard is, of course, the genetic analysis. The other differential diagnosis is FSHD. So here, the proximal weakness is mainly localized in the upper limbs, so the shoulder girdle. The scapular winging can be often asymmetrical, and this is combined with facial weakness. So these patients have difficulties closing the eyes. So some of them sleep with the eyes open at night. They have difficulties to whistle, to blow up the cheek. And they also have, in combination with the scapular winging, the distal weakness in the lower limbs. We call this the scapuloperoneal distribution of weakness. They show abdominal weakness, serum CK is mildly elevated, and the disease is inherited autosomal dominantly. So you see also here the atrophy of the shoulder, atrophy of the thoracal muscles over here, or also atrophy of the biceps here. These are some other examples of patients with FSHD. So you see clearly a facial weakness in this patient. So the scapular winging with difficulties of lifting the arms above the horizontal. 20% of the patients become non-ambulatory, so wheelchair bound. Yeah, so here you see again the biceps brachii atrophy and atrophy of the pectoralis muscle at the thorax. So another differential diagnosis of proximal weakness caused by a hereditary muscle disease is late onset Pompe disease, LOPD. So as you know, there are two types of Pompe disease. There's the infantile onset that starts below the age of 1 year, and there is the late onset juvenile or adult form. This one starts after the age of 1 year up to the 7th decade. So it can also give symptoms at a very late adult age. So the difference is that in infantile onset, there is no residual activity of the acid alpha glucosidase, GAA enzyme, whereas in the late onset form, it is milder because there is still some residual activity of GAA. And this enzyme takes care of the breakdown of glycogen in the lysosomes. So the infantile form is clearly much more severe with a floppy infant and also cardiomegaly. And this disease, the infantile form, is lethal below the age of 1 year if there is not a treatment started. The late onset form shows a typical proximal weakness with a Gowers sign, difficulties lifting the arms above the horizontal. And there is also restrictive respiratory involvement and involvement of the diaphragm, but there is no cardiomyopathy in the late onset form. So late onset Pompe disease is also called glycogen storage disease type 2 or GSD2. It's an autosomal recessive disease, and it's characterized by proximal weakness. Also a lot of axial weakness, as you can see here in this picture. So the dark red is the darker the color, the higher the percentages of patients showing weakness in these muscles. So you see it's really proximal and axial weakness. Respiratory insufficiency is frequent in patients with LOPD. There is no cardiomyopathy. Serum CK is mildly elevated, and as I already mentioned, the GAA enzymatic activity is reduced. It's important to recognize the disease because there is a treatment available, the enzyme replacement therapy, which are infusions that are given every 2 weeks to supplement this enzyme. So these are examples of patients with LOPD. So you can see the scapular winging, proximal weakness of the arms and shoulders. Sometimes patients also can have ptosis. These were some important genetic muscle disorders that can cause proximal weakness. Of course, there are also acquired muscle disorders that are involved in proximal weakness and that are an important differential diagnosis with the previous ones that we discussed. And that's in the first place, the idiopathic inflammatory myopathy or myositis. So these are also characterized by proximal weakness and often with skin changes. There can be an association with interstitial lung disease. There can also be an association with malignancies. And the muscle biopsy, we find inflammatory infiltrates. In the blood, we can see myositis-specific or myositis-associated antibodies. And at muscle MRI, we can see edema, which is a marker for inflammation, amongst others, and important to recognize, of course, because it's also treatable. These are some examples of the skin changes that can be seen in the patient. So you have this reddish skin change with edema, also on the back or on the décolleté sometimes. You can see these reddish changes on the dorsal sides of the finger on the fingers, and also in some cases, so this is what we call a Gautron sign or Gautron papals, and the mechanic hands, this points to these lesions that are present on the medial side of mainly the first, so the index finger and the thumb. Sometimes you can also see this on the feet, and this is often a sign of an antisynthetase syndrome. So the muscle MRI, this is an example of a patient with dermatomyositis. You use the STIR sequence to show edema. So STIR stands for short toe inversion recovery. It's a sequence that shows edema, and you see here in white, this is all edema. This corresponds to inflammation. If you look at the muscle biopsy in idiopathic inflammatory myopathies, you can see inflammatory infiltrates, as you see here. So these cells that are so inflammatory cells, and they also sometimes invade the muscle fibers, as you can see here. This is what we used to call polymyositis. This is a term that is not much used anymore. Here you see an example of dermatomyositis, where you can appreciate this perifascicular atrophy. So this is a fascicle, this is another fascicle, and you see on the sides of the fascicles, you see this atrophy of the muscle fibers. So the perifascicular atrophy and dermatomyositis. In this section, you can see many necrotic muscle fibers. Of course, if you see muscle necrosis, you also think of a muscular dystrophy or rhabdomyolysis. But in this case, this was a patient with an immune-mediated necrotic or necrotizing myopathy. And this is an example of IBM, inclusion body myositis, with rimmed vacuoles as inclusion bodies in the muscle fibers. So besides MRI of the muscles and the muscle biopsy, you also test in these patients myositis antibodies, and we have 2 types of myositis antibodies. We have the myositis associated antibodies. these are antibodies that are not only present in myositis, but also in connective tissue disorders. These are the ones that you can see here, so where there is an overlap with CTD or connective tissue disorders. Myositis-specific antibodies, they only occur in idiopathic inflammatory myopathies. And these are, for instance, the antibodies that are associated with the antisynthetase syndrome. The best well-known is the U1 antibody, but there are others as well. There are the antibodies that are associated with dermatomyositis, and some of them have a high association with malignancy. And then there are the two known antibodies associated with necrotizing, so the immune-mediated necrotizing myopathy. And then you also have IBM, so the inclusion body myositis, where there is one antibody identified so far. So if we talk about this group here, so the immune-mediated necrotizing myopathies, they make up 20% of the idiopathic inflammatory myopathies. And so far, there are two antibodies known, antibodies against signal recognition particle, or SRP, and antibodies against the HMGCR, which is the 3-hydroxy-3-methylglutaryl coenzyme A reductase. We know that this enzyme can be inhibited by statins, and this disease, so the immune-mediated necrotizing myopathy caused by the presence of these antibodies against HMGCR, is present in 65% of the cases have used statins at the time of the disease or before the start of the disease. So this means that 35% of the patients never had any contact with the statin. So you always have to think about it. In 30 to 40% of the cases, the antibody is not known. And so this is typically a disease with a subacute onset. There are often myalgia, dysphagia as well, and we see typically those necrotic muscle fibers on the muscle biopsy. Usually there are no or only very few inflammatory infiltrates. And this makes it difficult because you can make errors with a muscular dystrophy or a rhabdomyolysis, for instance, so a genetic cause. CK is highly elevated, up to 25,000. And it's very important to recognize the disease, of course, because it is treatable, but also important to say that in some cases it is therapy refractory. So if you look at those sections, that are 3 different patients, and if I would ask you, you would probably now say that these are patients with an idiopathic inflammatory myopathy, but take care, these are patients with a hereditary muscle disease. And so in several hereditary muscle diseases or muscular dystrophies, we can see also some inflammation and inflammatory infiltrates in the muscle biopsy. So this is an example of a DMD carrier, so a manifestating carrier. This is in a DMD patient, and this is in a dysferlin-related LGMD, as you can see here. So also very important always to look at the family history, to really take everything into account and not just only the biopsy, but really make a good history, good family history, and really to look for those also hereditary muscle diseases. It's important because some of these patients are getting treatment like steroids for a long time, although of course this does not help the symptoms if it is a hereditary disease. So we talked about the muscle causes of proximal weakness, so being hereditary, LGMD, and the differential diagnosis. We talked about acquired causes, the inflammatory idiopathic inflammatory myopathies. And now we will show an example of a non-muscle cause, neuromuscular cause of proximal weakness, being spinal muscular atrophy. And in the differential diagnosis with LGMD, that will be mainly type 3 and 4. But if we look at the different types, so there are 4 types of SMA. Type 1 has an onset of before 6 months, and milestones will not be achieved, so the patient will never sit. At least that was the case so far before the many treatments were available. Then we have type 2, that are the so-called sitters. They have a little bit later onset, between 6 and 18 months, and they can sit, but they will never walk. Then we have type 3, that are the walkers. That's onset in childhood, but after 1 year, after 12 months, and they are able to walk. But many of those patients will later on get into a wheelchair and they will lose ambulatory or ambulation. And type 4 is typically an older onset at adult age with normal milestones. So the disease, spinal muscular atrophy, is characterized by a proximal weakness. And important difference with the previous diseases that we discussed is that this is a neurogenic disease. So it's a disease at the level of the lower motor neuron. And here EMG can be an important tool to differentiate neurogenic with the other diseases that we have discussed. We often see fasciculations, which is also a neurogenic sign, in the extremities and also often at the tongue. There is a scoliosis often present with decreased forced vital capacity. There is no cardiac involvement in SMA. And CK can also be elevated, even though it's not a muscle disease. CK can be elevated up to 1,000 units per liter. So you cannot exclude a neurogenic disease due to an increased serum CK. It's an autosomal recessive disease with mainly deletions of the SMN1 gene. And it's also important to recognize the disease because nowadays there are treatments available that are the antisense oligonucleotides like risdiplam or Evrysdi or nusinersen or Spinraza. This is an example of a muscle biopsy, a section of a patient with SMA 3, and you see that there are fascicles with large or normal size fibers, and then you have those fascicles with very small atrophic muscle fibers. So this is really a typical biopsy that we can see in SMA. So then I come to my conclusion, so that proximal weakness can be caused by a broad spectrum of neuromuscular diseases that can either be genetic or acquired, and it can be localized at the level of the muscle, the peripheral nerve, the neuromuscular junction, or the lower motor neuron. And several of these diseases are treatable nowadays, so like the idiopathic inflammatory myopathies, like LOPD, like SMA. So a timely recognition and the correct diagnosis are very important. So this was the end of my presentation, and I'm very happy to take your questions.
Thank you very much, Crystal, for the presentation. So, someone have a question? Don't hesitate to raise your hand or write your question in the Q&A. Okay, so there's no question for now. Okay, Crystal. So no one seems to have a question. Ah, there's a question. So can you see the question, Crystal, in the Q&A section?
Yes, I will read it. So
Yes, please.
thank you, Thomas. Thomas Kisik. You ask, do you have any cases of very slow progressive necrotizing myopathies with anti-HMGCR antibodies, or do you always experience subacute patterns of symptoms? Well, subacute, It's often subacute, but you are right. Well, very slow progressive, I would not say, but it can be a little, it's not chronic either. It's, well, it can take a few months. But subacute would say up to 8 weeks approximately, but I think it could take a few months because in some patients it can be very severe, the phenotype, but there are also some patients in whom it's much less severe, and then sometimes it's only recognized over a few months. Do you agree? Was that, Thomas, what you wanted to ask me?
Thomas, if you want, you can talk.
Okay.
He said yes.
Thank you.
If someone have another question for Crystal. There's another question, Crystal.
Okay. So someone anonymous. Thank you. Yeah, I am a neurologist from the Philippines with limited genetic testing. Have you seen ASS, so endosynthetase syndrome patients with ELD, so interstitial lung disease, but no mechanics hands or Raynaud phenomenon? Yes, I have. So it can be present, but it does not have to be present. So this endosynthetase syndrome, it can be very, it can show many symptoms, but in some cases you only have the muscle symptoms and the interstitial lung disease. In some other cases, you will only have the muscle problems and the Raynaud phenomenon without the interstitial lung disease. So it's a very heterogeneous group of disorders, and the symptoms can be very variable. So to answer your question, yes, I have seen ASS patients with ELD, but no mechanic hands or no Raynaud phenomenon. And the other question is there any treatment options?
Yes, there are two other questions for you.
Yes. Is there any treatment options for for infantile onset Pompe disease since it is available? Yes, available for late onset. So indeed, so I mainly focused on the late onset Pompe disease, but the same therapy is available for the infantile onset Pompe disease. So it's Myozyme, it's intravenous enzyme that is delivered, and it's also given in infantile onset Pompe disease. So nowadays, if the diagnosis is made quickly and patients are started quickly with the treatment, then they will not die anymore from this disease. And the other question is
from Nicole.
Nicole. In my experience, in adults, the main challenge is to distinguish between a sum of acquired factors like degenerative spine and radiculopathy, intoxication, side effect of drugs, obesity, systemic disorder, physical inactivity, versus one of the causes you presented. Can you reflect on your experience? How do you approach this? Yes, of course, in adults and especially in elderly, you have a lot of comorbidities with all kinds of other potential causes of proximal weakness. Of course, then your, for instance, a muscle biopsy in some cases will be important to make the difference between the different causes. If you say, like your example, toxic causes, like certain drugs, of course, like patients that take Plaquenil, for instance, for some systemic rheumatoid disorders, you could do a muscle biopsy to differentiate. For instance, if it is Plaquenil, you will find a vacuolar myopathy, or if it's another cause, so you will be able to make some differentiations. But I agree that, of course, in elderly patients with a lot of comorbidities, it can be quite difficult to point a diagnosis, and in many cases it will also be a combination of different causes. I think, Nicole, is that, or you want to comment yourself still, or? I cannot see an answer, but
Nicole, if you want to talk, you can talk.
Can you hear me?
Yes.
Okay. No, I think that's very important to highlight that, because in my experience, also our residents are often searching for a rare disease, but in the patients above the age of 60, it's all very, very often, in my experience, a combination of acquired factors. So I think people should always continue thinking about very common acquired causes. Also, if there's just mild proximal weakness and a lot of comorbidities, side effects of drugs, etc., that is at the first place already much more likely than one of the rare diseases you presented. So I think it's always good to consider the sum of acquired factors as well.
Absolutely, I agree. So of course, this is not a presentation typically for the elderly, but I also included from 18 years on. But I agree that of course also other causes outside neuromuscular disorders need to be addressed as well. Absolutely.
Thank you.
I have another, Thomas.
Yes, from Mariam. Oh, yes,
yeah,
Thomas.
So Thomas, I want to ask if you perform genetic testing in patients with IBM, with histopathological signs of IBM, but without the antibodies, like Nonaka myopathy or other inherited IBMs. So if it's an elderly patient with a very typical clinical pattern of weakness, like swallowing difficulties to for the finger flex, so weakness of the finger flexors with a quadriceps weakness and atrophy. So if it's a very typical phenotype with typical findings on the muscle biopsy, and even without the antibodies, because the antibodies are often negative in sporadic IBM, I would not necessarily perform genetic testing if there is also no no family history for IBM. Of course, if something in the clinical phenotype does not fit with the sporadic IBM, or if there is a family history, or if there are other signs that perhaps if it is a very young patient, for instance, because sporadic IBM would occur above 60, 70 years, but if you have a patient of 30 years, of course, in that cases, I would perform genetic testing. So, but yeah. And
yes.
then I have Mariam still. Mariam,
yes.
So you ask, have you seen myopathy patients with a distal axonopathy on EMG? Yes, so I think clearly there are patients, and well, especially an elderly patient, to continue on that topic, there are quite some patients that also have a polyneuropathy, perhaps also for other reasons, like for instance, if they have diabetes as a comorbidity. But of course, there are also, besides the acquired causes, which are clearly more frequent, there are also some rare causes of a combined myopathy with so distal myopathy, distal neuropathy. There are also several genes known nowadays that can cause this combination. So this clearly exists, Mariam.
Mariam, if you want to add something, you can answer. Oh, she said thank you. Thank you.
You're welcome.
So I think it's the end of the question, unless someone have another question for Crystal. Okay. If you have a question, another question, Mariam, you can just write it and I will speak up for you. So I think this is the end, Crystal.
Okay.
So thank you again for your participation in our EuroNMD webinars. And you are always welcome to come back if you want.
Thank you. So thank you very much, Elizabeth, and thank you
You're
all
welcome.
for the very nice discussion, and hope to see you soon. Bye bye.
Yes.
Bye bye.
Bye.
Bye.